Right, so for those people that don't know me, my name's Ben Lowe. I'm one of the anaesthetic and ITU registrars, primarily a North trainee, so I don't come down to Leicester that often, but it's always good to come down to Glenfield. So I thought I'd just give a bit of a presentation on the National Institute of Health and Care Research Associate PI scheme. For those of you that don't know about it, it's quite an interesting scheme. It's been around for a little while, but only recently really opened up to anaesthetics and ITU. It ticks loads and loads of boxes for both curriculums. So this is just a bit of stage 3 anaesthetic curriculum, the key capabilities, but it basically ticks all the boxes on there, and likewise for the ICM curriculum. So it ticks lots of boxes, which is also helpful. So what is it? It's a 6-month scheme, and it's a 6-month scheme where you're affiliated to a study and you help the local PI. And it gives you a chance really to experience what it's like to be a PI on the scheme. And it gives you a bit more than just, so I think before the scheme existed, it was really difficult to get involved locally with research above and beyond just being on the delegation log and recruiting a few patients, because a lot of the different parts of the study that the PI gets involved in, you need to be a PI to actually sign off those forms or go to some of the meetings. Whereas being an associate PI more or less gives you the same role and abilities to sign things as the full PI, obviously under their mentorship. And also the brilliant thing with the associate PI scheme is that it lets you get some recognition for this as well, formally, and we'll talk a little bit more about that shortly. So why did they come up with it? So basically the NIHR wanted to get clinical research integrated a bit more into our training, and they wanted to encourage people to become PIs in the future. So certainly at some of the smaller hospitals, it's a massive problem getting people to volunteer to be PIs for the studies. So the idea was to that a bit more. By doing that, we'll have more people recruited to studies and help patients. So a little bit more about the structures of the scheme. So it's basically open to any health and care professional, so it's not just medics. And most studies are now affiliated to the scheme, so the study needs to be affiliated. There's a 6-month commitment, and there's a checklist of activities that you need to complete over that 6-month period. There's no funding associated with it, so this is something that you've got to do kind of as part of your training program. So you can use SPA time for it, and you do it alongside your core roles. You don't need time out of training. It's a couple of hours a week. It depends on the study and depends on the phase of the study. So right at the start, when you're setting up, you might need to put more work, time and effort in, and then when things are ticking over, then it's just fielding queries really. And the key thing is that you've got to be prospectively registered. You can't count time that you've done before you were registered with Associate PI scheme. So I thought I'd talk a little bit about my experience. So I first got involved as an Associate PI back in 2019. I'd done GCP, I'd been helping out on a few different studies, and this was at NUH. And the question really was, what could I do next to get a bit more involved locally in research, get a bit more of an understanding of what a PI does without being a consultant, because in effect for most of these things you've got to be a consultant, you've got to be staying at one site for the length of the study. So Dan Harvey over in Nottingham said, well, there's this new thing called the Associate PI scheme. It could be a good next step. There's this quite interesting study called REMAP-CAP. The methodology is interesting. We've got it set up here. We're struggling to recruit. So I thought, oh, that sounds good. For those of you that haven't heard of REMAP-CAP, it's an adaptive platform trial. It uses Bayesian stats, primarily a community-acquired pneumonia trial, but it's also a sleep study for pandemics. And you can probably see where this is going, as this was 2019. So in 2019, we're struggling to recruit. We have really low numbers, and so we didn't know how we were going to make it work, really. So being an associate PI gives you exposure to all the different issues you get in research. So the first big issue I had with REMAP-CAP was this difficulty in recruitment. One of the main arms for community-acquired pneumonia was looking at different antibiotic therapy. The problem was you were excluded from being randomised to the antibiotic arm if you'd had over a certain period of time of a different antibiotic, which was quite a short window by the time you took into account that it'd been in ED for a little bit before you come up to the unit. So we were missing loads of people because it was the research nurses recruiting during the day. So I managed to get a lot of the trainees on board and fellows on board. We got them on the delegation log. We got them randomising and recruiting, and that did improve recruitment to some degree. So that was really useful to have that kind of experience of difficulty in recruitment, which is quite a frequent problem you get in clinical trials. It was mutually beneficial, really. So that it was the first time the research team had really worked with an associate PI. So we were both finding off with what my role was really, but they loved it because it meant I could sign forms, and there's a lot of forms to sign. And getting hold of Dan Harvey, who was the PI for the study, is often challenging because he's doing lots and lots of things. So that worked out really well. Obviously, it was beneficial for me because it's something that can go on my CV. ARCP, it's tick, 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 tick. It involved lots of meetings with the research team, and especially initially when we were setting it up, doing all the usual. So getting the extra recruitment sorted out was a lot of badgering people to, do you want to come and be on the delegation log? You can recruit and randomise, selling the benefits of them for the ARCPs essentially. So that was what the initial workload was like, really. And then, as we all know, in 2020, there was this thing called COVID, and that suddenly changed the game, really, with this. So REMAP-CAP being a sleep study was the primary study for intensive care for COVID. From at a national level, there was a big push from the Department of Health and central government. All other research in the hospital basically got stopped and all resources got piled into COVID studies. So suddenly, from struggling to get things done, difficulty in getting equipoise on things and everything, there was a much bigger focus really on just letting us crack on. We obviously had loads of patients. One of the big challenges was with the way REMAP-CAP works, part of its adaptability and flexibility is that you can add new arms in as you go. But the problem is they all come in as amendments to the study, and each amendment has got to be signed off to at a local level as well, and then you've got to integrate all of that in. Also, each different arm that you put in there, you need to make sure that your team of consultants is going to be happy to randomise too, and that you've got equipoise. And I didn't really fully appreciate that. I think at the start there was no point in having an arm in there that you can't then actually randomise and recruit to, because if you have an arm in there and someone gets allocated to a treatment and then the consultant the next day doesn't agree with that and just goes off protocol, and that completely scupper to your research and you get those protocol violations. So that was a challenge initially. I think it's always a challenge as a trainee, having those conversations with a big group of consultants saying, "No, I've got this study, I think this treatment is a good idea," or "I think there should be equipoise for this, what are your views?" And you get all these kind of 1,000,001 emails coming back. But it was a useful experience. It was a useful bit of negotiation and an insight into some of the politics that occur. And what happened afterwards? So 2021 and 22, I was less involved in. So I've moved on from Nottingham, and actually, as we said, it's a 6-month period that you've got to put into this. And often that's a challenge with our rotations because they tend to be 6 months as a maximum. So if you're looking at this, I'd look ahead to where you're going next and make contact with them, ask what kind of studies they've got going and whether there's any on the associate PI scheme. I ended up, even though I wasn't at Nottingham, going back and doing some bits so I could keep up with it for a little bit longer, because the very first bit of my work with REMAP-CAP, I wasn't actually signed up fully on the scheme. So obviously, if you don't count anything retrospectively, then that doesn't count. So yeah, going into 2021, 2022, wasn't much input that I gave really, but the publication starts coming out of it. One of the benefits of the associate PI scheme is that you're actually recognised for the work that you put in. So in like the JAMA publications, there's an appendix there that's got all the PIs, and the associate PIs are listed there as well. So it's something small, but it's something recognisable. So it's widely endorsed by basically all the Royal Colleges. So whatever your speciality, so if you're a non-anaesthetist, non-intensivist, everyone recognised it. Like I said, it started off with the surgeons really. And this is just a bit of a graph to show the spread across different specialities. So like I said, it started off with surgery. So surgeons are the predominant alumni from the scheme really. So there's over 400 surgeons have been a member in the past. Anaesthetics is fast catching them up, about 350. And then you can see crit care part way along there. We're doing relatively well, actually, with over 200 associate PIs now, which is really good because considering when I was one of the first critical care associate PIs, and that's only back in 2019. So there's been a really rapid expansion there. How many different studies have we got? Well, there's now this is just the critical care ones, not the anaesthetics ones, but there's about 20 different studies available that you can join on to. So things like Mosaic, looking at bicarb, UK rock, so loads of different things. So find something you're interested in. More importantly, find something that's running at the unit that you're running at and that someone else is currently an associate PI on. So from what I understand, you can only have one associate PI on each study at a time at each site. So you just need to make sure that there's no one else doing it currently, which obviously the PI isn't. Again, the GMC recognise it as well, and they think it's valuable. Just a little bit about the study eligibility criteria. So it's got to be an NIHR portfolio study, or it's got to be an NIHR portfolio study, but they're now including non-commercial and commercial studies. And the commercial studies is a new part that's recently come on board. There's probably not many of them in anaesthetics and ITU, well, certainly in ITU. There's got to be at least 6 months of study activity, recruitment activity left, otherwise you won't be able to fulfil your 6-month input. And they've got to have a full setup with a clinical trials unit running and managing the study. Your speciality has also got to be supportive of it, but like I say, basically everyone is. And the PI and the study have got to be happy for you to facilitate patient level consent and get involved in the study really. It doesn't work if they're not going to let you do things. What do you have to be? Well, again, there's a little bit of overlap with the previous slide, but basically you can only be an associate PI for one study at a time. And like I said, there's only one associate PI per study per site. And actually, interestingly, you can't do this if your role is solely a research role. So the idea of this is to get people into research that otherwise wouldn't be heavily involved in research because they're primarily clinical. Again, that's 6-month commitment, and obviously the local PN has got to agree that you can do it. So how do you actually get involved? So first thing, make sure you're eligible. You'd all be eligible. And then find a study. So you can go through the NIHR website, but the easiest thing, to be honest, is just to ask whoever the research lead is where you're working and find out what studies are ongoing at the moment, and then get involved that way. Once you've done that, it's relatively straightforward. So you fill out an application form. Some of this has changed a little bit. I think it's now an online form rather than it was a Word document when I did it. And now you get access to e-learning that you fill out, and it's quite a good platform. This didn't exist when I did it. It wasn't quite structured, whereas now there's some e-learning modules for you to do. But I think that's quite useful. So you need GCP either if you don't have it right at the start, you need to complete it as part of this, but then you can work through these modules as well. GCP, for those who don't know, is good clinical practice, and that's a certificate that you do that teaches you all about it's mainly focused on consent around research and the ethical rules governing research, and anyone that's recruiting to most UK studies needs to have GCP. Actually, for Remap Cap, that was waived during the pandemic, so you didn't actually have to have GCP to recruit, but most of the time you do. You get a checklist once you've signed up, and basically e-learning is part of that checklist, but then there's other things you've got to be involved with. So that might be meetings with the research team, or recruiting patients, lots of different bits like that. And then at the end, you get signed off by the local PI, and then you get a sign off from the study kind of head office in the UK, and then you get a certificate. And basically by the end of it, you should have had a really good insight in what the PI role is, and know how studies are implemented locally and the issues and challenges that come up with it. And I found that really good, actually. And I feel like now, after having had that experience, when I become a consultant, if someone said, do you want to be a PI on a study, I'd actually be like, yeah, that's all right. I know what it involves. And I know some of the challenges I've got the confidence that I'm going to be able to negotiate most of them. And it's not just a complete punt in the dark, really. So it's fulfilling its role in that regard. So I'm not going to go into that. That's just a bit more about the checklist and the things you need to do on there. Yeah, the benefits, again, so it gives you a really good insight. It's a different insight to kind of locally led research, because the national and international studies that are on the portfolio, you get loads of evidence for various things. There's lots of different output from it with publications. It's actually really helpful for the sense as well. So I know Dan Harvey found it, said to me since it was invaluable at the time, because especially during this explosion of work during COVID, he was being pulled in multiple different directions. There was the workload from Remap Cap had kind of exploded, and me being there to fulfill at least part of that role enabled me to read through all the amendments, check various things, and then just use Dan as someone just to ask questions, to just clarify things rather than having to do all the work himself. So that was really useful. And of course, it encourages us to be PIs in the future. And the more PIs that we have, the more research we run locally, hopefully the better treatments we can implement for patients. A silly pie chart that shows that basically everyone stays engaged with research after they've finished. And I've yet to speak to someone that's done the associate PI scheme that's not found it useful in some way. I think even if you don't want to be involved in research long term, it's good to give you an insight. Study team, so the research nurses actually really loved it in the end. Again, I think it was mainly due to accessibility, so I was nice and easy to get hold of. I could sign things, and that's basically all they wanted, someone just to sign the forms. And most of the time they tell me, just sign this bit here, Ben, and I just go along and dutifully sign it. And that's what they needed. So they were very grateful for that, and actually it just made it run a little bit more straightforward on the ground. So you sometimes get queries about there'd be a protocol deviation, or there'd be a query about eligibility for the study, and because you've got a bit more clinical knowledge than the research nurses, you can go along and say, oh yeah, they would be suitable or they wouldn't be suitable. It's also, there's a bit there, so even right up at chief investigator level, there's been lots of really good feedback as well. So there's additional resources available. Like I said, the NIHR website is really useful. Just go on there, tells you exactly what you need to do, how to get involved. The workload will vary by the study, but it was by no means too onerous, and could easily be done within your kind of allocated SPA time. I did this when I was in kind of clinical fellow year. Well, started part way through that, and then I did a bit more when I was a trainee, but it didn't involve too much outside of work and additional things, so definitely worthwhile. And that's just the same again. But basically, there's a barcode that you can go straight to the resources there if you want. And has anyone got any questions about it? Nothing from in the room? Anything from over at the Royal?
In the next couple of weeks, I'm going to be starting recruitment to Mosaic, which you mentioned, and Ellie's our associate PI, so she's hopefully going to help quite a lot, because I've never been a PI before either, so we're going to learn together, I think. Yeah,
and I think it's probably really useful in that scenario as well, Zoe, because it's just a mountain of paperwork basically, and all these protocols and different bits of things that you never fully understand before you do it. The practicalities of getting it all running, you think you've done everything, and someone says, oh, you've not signed this bit or that bit. So yeah.
Yeah, they mostly want me to sign bits of paper. That's my role, is signing bits of paper. Yeah. Hopefully I will see some patients at some point.
Yeah, that was my main. I swear if they could have a stamp with my signature on, then I'd have been mainly redundant, but
yeah, probably.
No, and Mosaic's a good little study as well, and that it's quite pragmatic in how it's run, so it should be a good one to do.
Yeah, we've got, how many have we got, Martin? 3 or 4 studies going on at the minute?
It seems to be more every day.
Yeah, and we've had a couple of fellows that have been associate PIs for some of them. I think they've all left now, so we do have space more if anybody's here for 6 months.
No,
yeah. We do quite a lot of studies over here, so it is potential if people are here for any length of time. Cool, thanks, Ben.
No problem.
Great, so my name's Charlotte. I'm one of the ED trainees currently in ITU at the Royal, and I'm going to be talking today about a paper to do with Sigh ventilation in patients with trauma called the Sigh-Vent randomized clinical trial. So essentially this is just a little bit of background, but there's been several studies over the course of kind of 25 years that have shown that kind of traditional ventilation, whether that's volume or pressure controlled, will result in a near constant tidal volume. And the problem with this is that we worry about ventilator-induced lung injury. So one of these authors in a previous paper hypothesized that this is chiefly because of depletion of surfactant, that the type 2 pneumocytes rely on stretch to release surfactant, and that keeping a near constant tidal volume reduces stretch, and therefore you're not getting enough surfactant, and therefore this can cause ventilator-induced lung collapse. So the hypothesis here is that introducing sigh breaths should increase surfactant production, so thus reducing surface tension and atelectasis, and therefore reducing lung injury from ventilators. And as I said, it's been going on actually since kind of the early 2000s. There are a cluster of papers kind of around 2004, and then it kind of went a bit silent, and then people started re-looking at this in the last couple of years. The only bigger previous study was called the Protection Study, and that was published in 2021. And that actually didn't find that sigh breaths improved outcomes such as ventilator-free days or length of ITU stay. But, and I will talk about this more later, that study specifically looked at patients who already had ARDS. And therefore this study is a little bit different because it's looking at patients that are trauma patients but don't have ARDS at the outset. So the study objective, looking at the methods that they used, so their key question for research was, does adding sigh breaths to the usual care of trauma patients receiving mechanical ventilation improve clinical outcomes? And we'll talk about how those clinical outcomes are quantified a bit later on. So over to study design, it was a pragmatic randomized controlled trial. So pragmatic meaning real life patients in a true ITU setting, not kind of in the lab or whatever. The randomization was done 1-to-1. They used a randomization website to do that. All it said about that was that it randomized patients into blocks of 2, 4, 6, stratified by the center. It didn't go kind of further into exactly what website they used. The control group received usual care, but this was defined by the individual physician. So that could have been volume control, ventilation, it could have been pressure control, they could choose the tidal volume, they could choose the pressure. So obviously there's quite a big range in there. Again, I'll talk about it later. The intervention group received that same usual care, but with the addition of Sigh ventilations. And this was conducted across 15 trauma centres in the US over the course of 6 years. So in terms of who they used, inclusion exclusion criteria, in general, it was adults aged 18 and over, and they had to have been admitted due to trauma. They had to have been mechanically ventilated for less than 24 hours when they were recruited, and that they would need ventilation for more than 24 hours. They needed to have an expected survival of over 48 hours, and they needed to have one or more specific risk factors for developing ARDS. Interestingly, in exclusion criteria, they couldn't be on APRV as their usual care. So that was the only stipulation about what the usual care had to be. It couldn't be APRV. And then some other slightly more random ones, like currently serving a prison sentence, which was actually about 100 people they tried to recruit. So just a note on funding. So it was actually funded by the US Department of Defense, and this was why it specifically looked at trauma patients. It's not really entirely clear why the US Department of Defense wanted to look at Sigh ventilation in trauma patients, but it does explain why the population was very strictly defined to trauma. So looking now at the intervention. So the intervention in this study was the addition of Sigh ventilations, and I've written what they defined that as there. Essentially, it had to be sort of calculated manually by establishing what tidal volume would produce a plateau pressure of either 35 centimetres of water in a patient with normal BMI or 40 centimetres of water in those with a BMI of over 35. And I've put a few, so the mean tidal volume that was required for a Sigh ventilation was 939 mils, or 4.1 mils per kilo of their ideal body weight, which was almost twice the set tidal volume that they were on prior. And these Sighs were delivered over 5 seconds every 6 minutes, except if they were transporting them somewhere or they were in theatre. And I guess transporting also means if they were in a scanner, but they didn't say. So there were very many outcomes that they looked at, but we're just going to focus mainly on the primary outcome and the secondary endpoints as well. So the primary outcome was ventilator-free days. So the number of days of unassisted breathing up until day 28 without having to re-intubate, and any re-intubation reset the clock back to day 0. There were some pre-specified secondary endpoints, which include all-cause 28-day mortality, the number of ITU-free days to day 28, any complications, but they again were physician defined, and then their discharge status. There were some retrospective tertiary endpoints as well. I'm not going to really focus on these too much, but just to note that because they were post-hoc, they were determined in retrospect once they'd gathered the data. So patients were followed up daily until day 28, regardless of whether they were ventilated or extubated and whether they were still on ITU or not, or until they died. And any patient that died before the 28-day cutoff were assigned a ventilator-free day value of 0. So even if they'd managed without the ventilator for 27 days but died on day 28, they were kind of excluded, or not excluded, but given a value of 0. Yeah, and I've said already that if they re-intubated it, they had to start again. So a sample size calculation was performed, and they originally thought that they would need 916 patients. However, once a third of those had been recruited, they reevaluated that target and they actually adjusted it to 544 based on reduced power and revised standard deviation. So in the end, we'll look at that later actually. So statistical analysis. The primary analysis was via a Wilcoxon rank sum, but they used a lot of different statistical tests looking at the different outcomes, and this is where it did get a little bit complicated and confusing. All analysis was based on intention to treat, and obviously for things like survival, they used Kaplan-Meier survival curves. But the key for us was that the ventilator-free days was the primary outcome, and therefore that was the Wilcoxon rank sum method. So in the end, they recruited 524 patients, which was 96% of the 244 target. At that point, funding was pulled, and it's not entirely clear why, but that's why they didn't quite get up to 100%. 261 of them were randomised to the intervention group and 263 to the usual care group. And 99%, so 520 patients, were followed up and included in the primary analysis. And again, that was in the same ratio in the intervention group and control group. That's just an image showing how they essentially recruited and screened and randomized, and looks at some of those exclusion criteria again. So onto the results. So the primary outcome, as we spoke about earlier, was ventilator-free days, or VFDs, I've sometimes used here. So in the intervention group, there was a median of 18.4 ventilator-free days, and I've listed the interquartile range there, with a p-value of 0.08. And in the control group, there was a median of 16.1. The mean difference was 1.9 days between the groups, which was not a significant difference. But there was a smaller difference still in ventilator-free days when looking exclusively at survivors. So when you exclude anyone that died in either group, you actually see an even smaller difference between intervention and control. And in terms of kind of adverse outcomes, there were just 5 patients that had Sigh ventilation-related hypotension, 4 of whom required vasopressor support to manage and needed vasopressors every time that they had Sigh ventilations, but otherwise there were no specific safety concerns at all raised. And again, this is just a table taken from the paper that shows some of those numbers a bit more, and it also shows, as I said before, about excluding death, that difference is even smaller between the intervention group and the control group. So there were quite a lot of strengths of this study, which we'll focus on first. So first of all, there was a focused research question. It was clear what they were looking at. They used robust methods of randomization. They ended up with well-matched groups. So one of the things that I wondered about, first of all, was actually whether the 2 groups had similar levels of what they had defined as usual care. So were the 2 groups well-matched in terms of the number of patients on volume control, the number of patients on pressure control, etc. But actually, they used that in their randomization, and they were very, very well matched. There was a table that showed that. I think I've referred to table 1 if you look at the actual paper, that shows that they were very well matched. They had a clearly defined intervention and follow-up intervals. There was a robust sample size calculation and subsequent adjustment, and there were very minimal losses to follow up. And they used an intention to treat analysis. Looking first at kind of minor limitations. So the study wasn't blinded from investigators, but this is normally impossible to achieve when you're having a pragmatic study like this. So I put that down as a fairly minor limitation. Again, the trial was terminated very slightly early, but they were at 96% recruitment. So again, that was probably not a big problem. It was unclear why some of the patients were lost to follow-up. There was only one loss that was explicitly accounted for, which was that the patient had been discharged very early to the ward and then discharged home quite early within those 28 days, and they just couldn't trace them. It didn't say why the other few were lost to follow-up. I've put some of the statistical analysis was quite hard to follow. I'm not a statistician, but I have to say there are a lot of different outcomes using a lot of different statistical tests. And at points, I just couldn't really understand why they were using particular tests at particular points. There were some more significant limitations. So one of them it was something that actually the study authors themselves acknowledged, was that the decision to extubate is subjective. And since the physicians were not blinded, there's a risk of bias. So obviously the physician could choose when to extubate. And that might mean that in some cases, someone ends up being on a ventilator a little bit longer. And obviously if the primary outcome is a ventilator-free day, then people who are sort of pragmatically extubated a little bit earlier may appear to have done better based on ventilator-free days. But actually that in itself is quite subjective. Second of all, funding was, as I said before, by the Department of Defence, and it meant that they specifically had to look at trauma patients. And this narrowed the inclusion criteria significantly, but also probably resulted in a slightly younger, healthier population. And albeit this was the same for both the intervention and control groups, it was something also that the authors themselves acknowledged. However, they further went on and said that actually trauma patients have an inherently low incidence of ARDS. And so this study was not ideally suited to determining whether Sigh ventilation actually prevents ARDS, because the percentages were so low in the first place that the risk was so low, it was very hard to determine whether the risk was further lowered. Finally, I've suggested that there's also no consideration given to the labour intensity or practicalities of providing Sigh ventilations every 6 minutes. So, I mean, thinking of the sorts of things we do on ITU, rolls, washes, and other things, I'm not sure whether it would even be practical for a Sigh ventilation to be given every 6 minutes on the dot. And they didn't really talk about that at all in the paper. But that was pretty much everything. So in conclusion, the conclusion that was drawn by the authors was that the Sigh vent RCT did not find a statistically significant increase in ventilator-free days when Sigh ventilation was used in trauma patients compared with usual care, which was left to the individual physician's discretion. But as we've said, the caveat to that is that trauma patients are inherently at a low risk of ARDS. And therefore, to investigate this question more fully, you could either have a much larger cohort of trauma patients, or you could simply widen the inclusion criteria to include non-trauma patients. And while the study was therefore somewhat inconclusive, it did, though, suggest that providing Sigh ventilations is safe with only those 5 adverse outcomes, which means that a further study in the future would be safe and could therefore answer our questions more fully. Thank you. And that's the paper if anyone wants to look at it.
Thank you. Does anybody have any questions or comments? Do you think we should change it, what we do then, or not? No.
Can you hear me?
Yeah.
When you say that trauma patients are low risk for ARDS, what's the incidence?
I can't remember, I'm afraid. I think they stated an incidence, but I think it was, I want to say it was in the region of 4%, but I honestly can't remember.
I mean, I believe that if you class trauma as someone falling over and breaking their ankle, but
Yeah, if
I
it's
think
trauma less.
if it's a proper trauma, the incidence of ARDS is quite high, I think, isn't it?
You know more than me.
And we get referred enough of them.
Yeah.
Exactly. That's Dr. Charlton, by the way, is one of the experts.
Yeah, it sounded a bit weird, but it made up quite a significant proportion of their own discussion in the paper. It was sort of their main point. So I just wasn't sure. I don't know a lot about trauma, I have to admit.
Do you want to get rid of the, just go click back onto Teams so that everybody can see that? Yeah. Any other comments, not particularly? Please fill in the feedback and get a certificate, I'm sure Ben and Charlotte will appreciate.
How were the rest provided?
How are the rest provided? I don't know.
Manually on website.
Yeah, manually, yeah.
Someone was coming around and just squeezed the button.
Yeah.
Doing an exposure code.
I mean, to be honest, they didn't really say. I had to look on Google to find out, really. They didn't actually say how they did it in the study, but it sounded labour intensive to me. And it didn't sound like we would really be able to do it very accurately.
They've got respiratory physios doing clinical ventilation in States, don't they? Not the
Yeah, they
doctors. So they would assign the dedicated
Yeah.
to that.
I think you can, Matt, do you know, you can get certain ventilators that will do it for you if they've got it, they've prepared software.
Maybe that's why they
Oh, they
provided
did.
the software for that.
They did talk about particular Draeger ventilator. One of the exclusion criterion, was that they had to have a specific Draeger ventilator available, and if it wasn't available, they couldn't be recruited. So it does suggest that they were able to do it automatically on that particular ventilator, but they didn't really explicitly ever say that.
Thank you. Thanks, everybody. Good weekend.